Good evening, everybody, and welcome to this webinar on how can contrast enhanced ultrasound help face the rising burden of liver disease, a practical approach. I'm Adrian Lim. I'm a radiologist based at Imperial College, and I have a great interest in contrast ultrasound and have been using it for many years. We are very fortunate and privileged to have an expert panelist and speakers this evening across all specialties. And just a couple of bits of housekeeping, just to inform you that this session will be recorded and that we will be taking most of the questions at the end of the three talks this evening. However, if there are any burning questions or ones that we could address very quickly after each talk, I will highlight that. The way to ask a question is via the question and answer chat button. So if you type your questions in, then make sure that they are appropriately addressed. So without further ado, it gives me great pleasure in introducing my good friend and colleague, Professor Shahid Khan, as our first speaker. Professor Khan is a professor of hepatology at Imperial College London, and he is an international expert on disease of the liver, in particular fatty liver disease and primary liver cancer, but is also an enthusiast and expert on quite a number of imaging modalities that he utilizes. He has published extensively, having authored over 100 peer-reviewed publications, including research articles, reviews, and book chapters. Professor Khan is currently chair of the Cholangiocarcinoma UK and serves on the Hepatobiliary Cancer National Subgroup Committee and numerous advisory boards of International Liver Cancer Association and the Cholangiocarcinoma Charity. He's also a great educator, and it is a great pleasure for me to ask him to set the scene with his talk on the title of The Rising Burden of Liver Disease in the United Kingdom. Thank you, Shahid.
I just wanted to start by thanking you, Adrian, and Jerome Gianfranco and the organizers for putting together this webinar. It's a very interesting topic. It's a pleasure to be here. I was given the title, The Rising Burden of Liver Disease in the United Kingdom, and then to also talk a little bit about what, given this increase in liver disease, what we as hepatologists need and hope from our radiology colleagues and industry partners who create these amazing new machines. Okay, so I'm going to talk about the burden of liver disease, the diagnostic needs in liver patients, the limitations of standard conventional ultrasound. Ultrasound obviously been used for decades and decades across all of medicine, and what hepatologists expect, hope and need from. And most of my talk is going to be on the first bit of this, the burden of liver disease in the UK. There was a big piece of work over the last few years led by Professor Roger Williams, the late Roger Williams, outstanding hepatologist, for and as part of the Lancet Commission to look at the liver disease nationally across the UK. And what this study shows is, what this graph shows is how mortality rates in people under the age of 65, how liver disease in red has been increasing, whereas the other big causes of mortality rates such as respiratory disease, cancer, etc., have been relatively stable and plateauing. But the rise in liver disease has been pretty big for liver. And also of note, you can see in the green bar that there were 5 years following the introduction of a 2% escalator duty tax on alcohol to slightly increase the cost of alcohol. And both overall consumption and mortality figures went down, but bounced back when that duty tax was removed by a subsequent chancellor, and I'll come back to that. So again, this shows focusing on alcohol and alcohol-related death. One can see that as during that period when the duty escalated, the 2% tax duty was there, both overall consumption and mortality figures started to go down, but started to go back up again when that tax was removed. This is a political debate, one of the debates that's going on with liver disease in the country about what's called a minimum unit pricing tax to try and reduce alcohol consumption. As I've said, I'm grateful to a lot of the work Roger Williams and his team did for the Lancet Commission for the UK. The main reason that liver disease is increasing is from two main things: obesity and alcohol excess. And there's some viral hepatitis in there, and I will talk a little bit about viral hepatitis, but most of my talk on the burden of liver disease is going to be on obesity and alcohol, because they are the two key drivers in the UK, and I suspect in most parts of the world. In 2018, there were over 1 million NHS admissions for liver disease, and it's estimated that the cost of the NHS were about £3.5 billion per year for liver disease-related admissions only. And it's thought that next year, liver disease in the UK will overtake heart disease as the cause of the number of years of premature working life lost for illness. So let's talk a little bit about NAFLD, NAFLD, non-alcoholic fatty liver disease first. So NAFLD is the association of steatosis, macrovascular steatosis, so fat in the liver, which can lead to inflammatory changes in fibrosis, and in particular in people who are overweight. And this has been known for several decades. And it's now considered that NAFLD is the liver manifestation of the metabolic syndrome. But the metabolic syndrome is very common all over the world. It's where you have obesity, associated type 2 diabetes and insulin resistance, hypertension, hyperlipidemia, often in women associated with polycystic ovaries. And now it's recognized that liver disease is the liver manifestation, probably, of the metabolic syndrome. Now, today, the commonest cause of abnormal liver tests presenting in the clinic is NAFLD, and is increasing globally. Secondary to rising levels of obesity, and it's estimated that probably about 1 in 3 adults have NAFLD. Now, the issue with NAFLD is that NAFLD is a spectrum. You go from a healthy liver to NAFLD, and it's estimated that 30% of people, maybe 20 to 30%, have NAFLD. And a proportion of people with NAFLD will go on to the next stage of the disease, which is NASH, which is actual inflammation and scarring. And then once scarring is developing, then patients can progress to cirrhosis. And once people have cirrhosis, they're at risk of liver failure and liver cancer. And I'll be talking a bit about those. Now, the scary thing is that this process, which takes years and years and years, is usually asymptomatic until patients have not just cirrhosis, but decompensated cirrhosis. And once they have actually or developed cancer. And even the cancer is only symptomatic if it's very large. So there are hundreds of thousands of people walking around who've got NASH and fibrosis and even cirrhosis who have no idea. And every week in the emergency department at my hospital and other hospitals, we will see people coming in with the first signs of decompensated cirrhosis. It could be jaundice, it could be ascites, it could be variceal bleeding. And that's the first time they know that they've got a liver problem, even though that liver has been chronically damaged for many years. Just to show you the histology, hepatologists like looking at biopsies, so just bear with me while I show some pictures. So this is simple steatosis, simple fatty liver, which can, in a proportion of patients, progress to NASH, where there's not just fatty liver, but ballooning of cells, lobular inflammation, and a proportion of these patients will go into develop cirrhosis. I mean, this trichrome stain, you can see the scar tissue here and here. So there's a nodule of liver, which is inflamed, surrounded by scar tissue, which is cirrhosis. So our French cousins have been aware of the importance of the liver and fatty liver for many years, as this classic cartoon shows. And I just wanted to show you. This is some of you may have seen this before. It's quite visually impressive, and it shows the obesity trends amongst US adults between 1985 and and the end of the last century. So just to indicate, just give you an idea of the obesity rise that's happening that's happened in the US and pretty much every other country. So these are the states, the US different states. The darker the color, the greater the proportion of adults in that state who have thought to have obesity. So obesity, so BMI over 30, I'm not talking about mildly overweight. And this is in 1985, and we can see, I'm going to show you how the picture changes over the subsequent few years. You should just watch how the color changes. And that trend has continued over the past couple of decades. So as I've said, a proportion of people will, from NAFLD, a small proportion of people with NAFLD will develop cirrhosis. So it's only a few percent, probably around maybe 5% on average of people with NAFLD will develop cirrhosis overall. And half of those people will probably not die from cirrhosis, but may die from another metabolic associated condition, such as angina, ischemic heart disease, stroke, some diabetic complication, etc. But even if it's only 1 or 2% of people with NAFLD who go on to get cirrhosis and have serious liver-related morbidity, liver failure, liver cancer, needing liver transplant, 1% of a third of the world's adult population is a lot of liver disease now and even more in the future. So admissions attributed to obesity-related health conditions, not just fatty liver, but other obesity-related conditions, has it increased 150% since 2010. I do have references somewhere at the bottom. It's now estimated that 50% of the UK population are overweight, so BMI over 25. Now I know that BMI is a bit of a blunt tool, and 25% of adults are believed to be drinking at hazardous levels, i.e. above the recommended limit advised by the British Liver Association of 14 units a week. There is a synergistic effect of people with NAFLD and metabolic syndrome who also drink and have ARLD, alcohol-related liver disease. And of course, some of those patients may also have chronic hepatitis B and C, and so are at risk of even more significant and quicker liver disease. And it's estimated that obesity-related illness costs the NHS over £6 billion per year. And it's not just liver disease we're talking about. It is thought that 40% of the commonest cancers are thought to be attributable to behavior and environmental factors, including alcohol and obesity. This just shows the increase in across the 4 nations of the United Kingdom, England, Scotland, Wales, and Northern Ireland, from the beginning of this century. Consultant episodes for fatty liver disease. So this is happening across all parts of the UK, the increase in that. And now, today in the UK, NAFLD is the second commonest cause for liver transplant, and the first is alcohol related. So most of the liver transplants that occur in the UK now because of end-stage decompensated cirrhosis or liver cancer are done due to alcohol-related or fatty liver disease. And another way of looking at the impact of fatty liver is bariatric surgery. So I've put there the eligibility for NICE, the National Institute for Clinical Excellence, that decide which treatments should and shouldn't be funded by the NHS. And 2 million people fulfill the NICE eligibility for bariatric surgery to treat severe obesity, and fatty liver is one of the indications. And there the indications are. Now fatty liver is often one of the indications, but only less than 6,000 operations are done per annum. So although bariatric surgery is often a very successful treatment for obesity, reversing the fatty liver, etc., it's not without complications. But even though it can be effective, more effective probably than drugs, the number of actual procedures that have been done is less than 0.5% of the eligible population, according to NICE's own eligibility criteria. And this just shows the predicted international obesity rates from a selection of countries going ahead for the next few years. Okay, so I just want to talk a little bit about alcohol, moving on from obesity to alcohol-related liver disease, having made the point that obesity-related liver disease is a very significant rising issue. According to the Foundation for Liver Research, the NHS will incur £17 billion worth of costs related to alcohol misuse over the next 5 years. If we look at current alcohol consumption in England, it's estimated that there are only 17% are abstainers, and 25% approximately of the population are drinking above recommended potentially dangerous levels of alcohol. And this heat map shows the mortality per 100,000 attributable to alcohol from 2000 to 2015. And as the color gets darker, the number of deaths per 100,000 is higher. And you can see that from 2015 to 2000, there's been a general worsening of mortality. And also what is of note is that alcohol-related deaths did decrease during this alcohol duty escalator, but then, as I said, did increase. And the other thing to notice is that if you compare socio-economically, the least deprived to the most deprived, it's although alcohol-related liver disease affects all people from whatever their wealth status, the most deprived suffer more. The main age group for alcohol-related admissions is 45 to 54, so relatively young people, 61% male. And as I've said, liver disease will overtake heart disease as the main cause of years of premature working life lost, as this graph shows. And certainly anecdotally, I was talking to my colleagues earlier today, who've seen in the last year or so, really since the pandemic, we've seen even more alcohol-related, alcoholic hepatitis-related admission. Okay, so just talk a little bit about chronic hepatitis C. Chronic hepatitis C has been steadily increasing since the 1990s. We're getting better at diagnosing. We didn't know about it. We weren't able to test for hepatitis C until 1992. There's hepatitis C used to be the biggest cause for hospital admissions and transplant, but since the advent of new antiviral directly acting antiviral drugs, which have been phenomenal, 95% almost cure rate after a few weeks of treatment, the hepatitis C related mortality and decompensation has significantly gone down. So much so that WHO Global Health Strategy team thinks that HCV-related mortality can be reduced globally by almost 2/3 by the end of this decade, if we can get these drugs out to everyone in the world who has chronic hepatitis C. It's not the treatment now, it's actually finding people who have the infection. What about chronic hepatitis B? The UK has always had a very low incidence and prevalence for hepatitis B. There's no real evidence of it particularly going up. Obviously, liver centres will see people with hepatitis B, so we have a skewed view of hepatitis B. But it's relatively small fry in the UK anyway, compared to alcohol and obesity. But chronic hepatitis B has very high prevalence rates in other parts of the world. Okay, so I've shown you that chronic liver disease is increasing, that chronic liver disease, and what the main drivers for that rise in chronic liver disease is. So why are we worried about chronic liver disease? Well, we worry about chronic liver disease because of its complications. So its complications include liver failure, portal hypertension, resulting in ascites and varices, and these are all potentially fatal diseases, encephalopathy, which is severely disabling and potentially fatal, coagulopathy, portal vein thrombosis, higher risk of sepsis, risk of hepatorenal syndrome, and if that wasn't enough, primary liver cancer. So I'm going to talk a little bit about primary liver cancer, and by that I really mean hepatocellular carcinoma and cholangiocarcinoma. In the UK, these two primary liver cancers are estimated to cause approximately about 5,000 or 6,000 deaths per year. And the overall 5-year survival for both of these cancers is relatively poor because diagnosis is late, there's lack of accurate biomarkers. If somehow they're found early and resected, mortality, survival rather is good, but that's a minority of cases. And if surgery is not an option, there's a lack of effective treatments. And even if you resect, there's a high rate of recurrence because these are aggressive tumors. So primary liver cancer is not just important in the UK, but actually globally. These primary liver cancers are believed in multiple epidemiological studies to be the third, some people say the second most common cause of death from cancer in humans on this planet. The primary liver cancer is a huge, huge cancer burden for humanity. Estimated to be cause approximately 1 million cases per year. Most are diagnosed, as I said, in advanced stage. The majority of primary liver cancers are HCCs, hepatocellular cancers, and the vast majority of HCCs occur on the background of chronic liver disease. It's not impossible, but it is uncommon to see HCC in someone who does not have any past history of chronic liver disease. And chronic hepatitis and cirrhosis of any cause, if the patient has that, they have somewhere around 2 or 3% annual risk of HCC. Globally, the highest rates are in Asia and Africa. Across the world, wherever HCC occurs, men are affected twice as commonly as women. Mongolia has the highest incidence, although China has the highest number of cases because it has the world's largest population. And wherever you look, though, globally, Europe, China, Mongolia, Asia, Australasia, the prognosis of HCC is overall poor with similar incidence and mortality rates. This just shows the global distribution of HCC, showing in the red areas where the incidence is particularly highest. But remember that as this cancer most occurs on the background of chronic liver disease, and chronic liver disease is increasing, and it's particularly due to fatty liver, and so these numbers and these shadows might change over time. This is here in the UK, data from Burton et al. Just published a couple of years ago, showing how incidence and mortality in men, women has increased over since the beginning of this century. In fact, in between 1997 and 2016, there were 62,000 cases of primary liver cancer, of which 38% were thought to be intrahepatic cholangiocarcinoma. So that brings me on to cholangiocarcinoma. Cholangiocarcinoma is a malignancy arising from the epithelium anywhere along the biliary tree. And based on the original location, the cholangiocarcinomas are divided into three subgroups: intrahepatic, arising within the liver parenchyma itself above the second order bile ducts, and intrahepatic cholangiocarcinoma forming the second commonest type of primary liver cancer. And then there's distal or extrahepatic cholangiocarcinoma below the cystic duct, and in the middle around the hilum of the perihylic cholangiocarcinoma. So just some very recent epidemiology in cholangiocarcinoma. There's a very recent, just finished project sponsored by the AMMF, which is the National Cholangiocarcinoma Charity, in partnership with Cholangiocarcinoma UK and Imperial, and I was fortunate enough to be leading this partnership with the Public Health England to look at the epidemiology of cholangiocarcinoma by subtype. And what we found is that, similar to HCC, cholangiocarcinoma had also increased, but the main type of cholangiocarcinoma that had increased was intrahepatic cholangiocarcinoma. So intrahepatic cholangiocarcinoma, the one that arises within the liver, is the one that's increasing most, and it is now well recognized that intrahepatic cholangiocarcinoma, chronic liver disease, is an independent risk factor, not just for HCC, but for intrahepatic cholangiocarcinoma as well, and that is now recognized. So, given what I've said about rising liver disease, the risks of the complications of liver disease, what do we need from our friends in radiology and imaging? Well, we need to be able to know if someone's got a fatty liver. We need to be able to risk stratify the severity of liver disease, because, as I've explained, liver disease, fatty liver is very common, but only a proportion will go on to develop fibrosis. And although the definitive gold standard test for liver fibrosis is a biopsy, it's simply logistically impossible to biopsy a third of the adult population every few years. So we need a way to see whether someone has liver fibrosis, and elastography associated with ultrasound has come to the rescue over the past few years for that. And also, patients with liver disease may have other causes for abdominal pain or jaundice not related to the cirrhosis, and so it's important that we are able to do that. We also need to be able to screen for complications of chronic liver disease to enable early and effective intervention. So, for example, we need to be able to screen for signs of portal hypertension before patients get symptoms, so we know whether to do endoscopy, start them on beta blockers to prevent variceal banding, to look for developing portal vein thrombosis so we can anticoagulate, for example. And of course, the development of ascites so we can start them on diuretics to prevent them getting SBP, ascitic infection, which carries a high mortality. And of course, the other big complication of chronic liver disease we need to be able to pick up early is liver cancer, particularly HCC. There are biomarkers in serum for HCC, the alpha-fetoprotein protein, and for cholangiocarcinoma, but they are low sensitivity and not very specific. Using CT on a regular basis, remember, patients with cirrhosis have a 2 to 4% risk of HCC every year. It's a lot of radiation, a lot of cost, risk of renal impairment because you have to use contrast. MRI, there are several contraindications to MRI. MRI is also expensive and it's quite time consuming. It takes an hour of scanning time. You can't have an MRI if you've got a defibrillator or pacemaker, or you're claustrophobic, or you've got cochlear implants, etc. So we need something that's easy to use and highly sensitive. So it's important to make the diagnosis of HCC and cholangio early, because as with any cancer, the smaller the lesion, the earlier you pick it up, the more likely it is to be resectable, and the less likely that there's going to be microscopic vascular invasion, and therefore the greater the chance of cure. So classically for HCC, diagnosis is made radiologically. In fact, HCC is the only cancer in humans, as far as I'm aware, the odd pancreatic cancer maybe, where you are allowed to make a diagnosis of cancer without a biopsy. In any other cancer, the oncologist will not get out of bed unless you can show them cancer cells on cytology or histology. But in HCC, it is deemed to be an exception. This is a very busy looking slide. This is the algorithm, the BCLC Barcelona Cancer Liver Clinic staging system for HCC that is used to some extent loosely by most of the Western world. And what I want to just show you here is that it just emphasizes that if you pick up the cancer at early stages, so stage 0A or B, there's a chance of cure, 5 years survival, or even intermediate stage 2.5 years survival. But you see how, so just showing you how the difference in survival depending on the stage. And one of the biggest things about the stage is the actual size of the HCC. That goes into the staging system for HCC. But tumors do not cause symptoms at this stage. And just to show why contrast imaging gives you a diagnosis of HCC, it's to do very specifically with the development of nodules in cirrhosis. So when people have cirrhosis, they have RNs, which are regenerative nodules. And remember, the liver is unique in that it has two main blood supplies. It's got a portal vein. Veins normally take blood away from organs, but the liver has a big vein taking blood towards it, the portal vein, as well as an arterial supply, the hepatic artery. Now, when a patient with cirrhosis has just regenerative nodules, the blood supply is predominantly from the portal venous system. But if that tumor develops enough mutations and turns cancer, well, first it will turn dysplastic, a low-grade DN dysplastic to a high-grade dysplastic nodule, and then and then eventually to moderately differentiated and severely differentiated HCC. And during that pathogenic process, the blood supply changes from predominantly portal supply to an abnormal arterial supply. Arterialization is a key pathogenic step in the development of HCC. This just shows, for example, on an MRI, that this person had an ultrasound on screening, picked up an HCC in the bottom of the right lobe there. There's the arterialization just here. And then on the portal venous phase, there was washout. And if you see that in a patient with cirrhosis, then you're allowed to diagnose HCC and go on to book surgery or ablation or any other treatment, or TACE, for example. So the limitations of conventional ultrasound is that standard ultrasound won't tell you whether there's fibrosis or quantify how much liver fat there is. The new FibroScans tell us how much fat someone has, and that can be quite a good biological motivator for patients. You can tell them how much fat they have in the liver, give them a number, encourages them to try and bring that number down. And of course, when it comes to cancer surveillance, cannot accurately differentiate between different types of liver lesions. So finally, what do hepatologists hope from contrast ultrasound that will offer in addition to conventional ultrasound? Well, we need it to be able to deliver everything conventional ultrasound delivers, including Dopplers of portal vessels and hepatic vessels. But particularly for cancer, an accurate diagnosis of liver lesions. Liver lumps are very common. They can be benign, they can be intrahepatic cholangiocarcinoma or HCC, or they can be metastatic. And being able to differentiate is a hugely important clinical need. Ideally combined with measurements of stiffness to correlate risk of fibrosis and fat measurements. Also, of course, if we have a technique that can do all this, We want it to be widespread, not just one or two centres or one person in each hospital can do it. Accessible, safe, quick, and particularly in today's climate, cheap. So I hope that has been helpful in setting the scene. I hope that was okay. I've run about 2 minutes over, or 1 minute over. I hope that's not too bad.
Thank you, Shahid. We're going to let you go on. Thank you for that excellent talk and very sobering thought on the rising disease that is coming to us. So, well, thank you very much for setting the scene so nicely. There are no burning questions at the moment, but we'll certainly take questions at the end of the sessions.